Thank you for giving me the chance to tell you some of the things that we're doing in Kampala in relation to this great problem of maternal health. And I'm just going to give an overview, and Annette and Catherine will go in a little bit more detail about a couple of the research projects. Now, this map really tells you everything. Maternal mortality is really an African problem, and it's sub-Saharan Africa particularly. And this was the one Millennium Development Goal which was not, that did not reach its target. And I think that these figures, although they are slightly better, really haven't shifted very much. Certainly, Annette will tell you in Uganda, they really haven't shifted that much. Now, of course, there are a lot of people, as we've heard, who are interested in this, governments, NGOs, charities. So what is it that an institution like Cambridge can actually do in relation to maternal health? And there are big challenges, actually, in doing this. And one of them is funding. And this is from the MRC, from their MRC Global Health funding. And you see only 4% goes on maternal and reproductive health. And the most of it goes on infection. So that is one challenge to start with. So what are the women dying of? Well, at the moment of childbirth, these are the 4 major causes of death: preeclampsia, infection, hemorrhage, and obstructed labour. And they're roughly equal, those causes of death, a bit slightly different in different areas. Now, intriguingly, the most numbers of deaths occur here. This is the maternal neonatality rate, and this is the birth weight here. And you can see most of the deaths of both the mothers and the babies are occurring at the extremes of the normal birth weight distribution. So it's much better to be born between 3 and 4 kilograms. And if you get above 4.5, then the rate starts going up. And that is because it's obviously better to have a big baby. This is the dilemma. But if you get the baby too big, it won't get out. It basically gets stuck, and one ends up with these problems in the baby and in the mother. The other extreme, if the baby doesn't get enough nutrients in utero and oxygen in utero, then we have these problems and this major disease of women, preeclampsia. Now, preeclampsia is a mysterious name for a very mysterious disease, and it's quite salutary to think why, in the 21st century, this major disease we know so little about. And after working on this for many years, I've come to the conclusion that it's because it's a disease of women. And it's a disease only of pregnant women, and particularly of African pregnant women. And when we think about all the other diseases we know a lot about now, cancer and heart disease and infections and autoimmunity, this disease stands out as still being a mystery. And let me now tell you how I got interested in working in preeclampsia in Africa, because I worked on preeclampsia for about 25 years. In 2008, Annette, who is going to hear in a minute, was an obstetrician in Kampala and very upset by the numbers of women she saw with preeclampsia. And she'd seen that they just got this MUI fund from, led by Alison Elliott and with David in Cambridge, to train African scientists. But it was in infection and immunity. But Annette was quite clever, and she put into Google Cambridge, preeclampsia, and immunology. And I work on the immunology of preeclampsia. So she managed to get her PhD under this MUI program, working on the immunology of preeclampsia, despite the fact MUI really was on infection and immunity. Now, she first arrived And I was really had to be persuaded, actually, I should say, first of all, by David Dunn, that it was possible to do a research project on preeclampsia in Africa. But he arrived in my office, and by the time he'd left, I had been persuaded. I must say that it's really been one of the most rewarding experiences I've ever done. It's added a whole new dimension to my work, both here and in other areas across maternal health. So Annette arrived, and we did have a lot of challenges, because I said, well, how can you get enough women to work on with preeclampsia if we're going to look at the genetics of this disease? How can we, because it had taken me about 10 years in the UK to collect a cohort that was big enough to actually do the work on. But of course in the Rosie we have 6,000 deliveries a year, 2% of those roughly are affected by a preeclampsia. So then Annette, I said, well, how many deliveries do you have? She said 32,000 deliveries a year in Malago Hospital. I think it's the biggest maternity hospital in the world. And 8% of those women have preeclampsia. So on any one day you go in there, there will be 5 or 6 women with severe preeclampsia. So I began to see that this was actually an opportunity, not just a problem, it was an opportunity to actually see we could actually do some research. So she's going to tell you more about it, but let me just tell you a few things about what preeclampsia is. And this is how we diagnose it in the 21st century. We stand a woman on a weighing scales, we measure the blood pressure, and we see if they've got swelling, edema. This is how primitive it still is. We cannot predict it, we cannot prevent it. The only treatment we have is to deliver the mother, and particularly the placenta, which is the source of this disease. And that, of course, because it often presents itself early in gestation, under 30 weeks, means the baby will die. And if you don't get delivery of the baby, then eclampsia, which is a fit, a bolt from the blue, occurs. And this we see about once a year in the Rosie Hospital here, but in Malago Hospital about twice a week. That is the difference. And you can see from this poster on the wall of the hospital, this is common, this is warning women that this is likely to happen. Now, what goes wrong in preeclampsia, I just very briefly tell you, it's really a fascinating problem. It's to do with how the boundary is drawn between two genetically different individuals, the mother and the baby. Because, of course, the baby has half its genes from the father, and it is therefore foreign, in immunological terms, foreign or non-self to the mother. And the boundary between these two individuals is actually where this red line is here, which is where the placenta implants into the uterus. And the placenta is made by the baby, so it also has father's genes. And what goes wrong in preeclampsia is that this territorial demarcation, this boundary line between the mother and the baby, is not drawn in the right place. And we think, we have pretty good evidence now, that that's partly regulated by the immune system, by the recognition of the non-self, the father's genes, in that placenta. So the father has a lot to do with preeclampsia. And there are certain fathers who are very dangerous. And we almost know who they are now, but I'm not going to tell you today. So if I just go through this slide slowly, so if we look down here, the side, you can see these are the weeks of pregnancy in the 3 trimesters of pregnancy. So what is going wrong in preeclampsia, this boundary here, which is needed to allocate the resources, enough resources to the baby, but protect the mother from actually being parasitized by this placenta. It's absolutely critical boundary. And if that goes wrong here, it happens very early on in the first 12 weeks. So by 12 weeks, the mother, it's set whether she will get preeclampsia or not. Because of this, the blood flow from the uterus, from the mother, which is carrying all the oxygen and nutrients she needs, is reduced. And eventually, later on in pregnancy, at some stage around here, the placenta becomes stressed. And that triggers a syndrome in the mother that affects the blood vessels all over the body. And everything that blood vessels do, like regulate blood pressure, fluid balance, are affected, and she can get this syndrome of preeclampsia, a range of symptoms, and the baby will not grow because it hasn't had enough nutrients, and it may be delivered, and it may even die in utero. So that is basically what happens. Now, why does it happen is, of course, a great question, and there is evidence that more than half of the susceptibility to this is genetic. About 55% is genetic, with a contribution mainly more from the mother, but some also from the father in the fetus. And you can see that I've just taken this slide, it's from California, but you can see that of all the different ethnic groups there, even in California, where there's a good healthcare system, you see that there is maternal mortality is much higher in African Americans. Now, the same is true in London, so that this disease is affecting Africans wherever they are in the world more commonly than any other population. Now, what are these genes that are making these women susceptible? And we can see that we have some immune system genes in the mother that will bind to these fathers' genes expressed by the placenta. And these are the genes that we've been studying in Kampala. And actually, Africa is the place to study this disease. It's a real example of that one should study a problem in the population who's most affected by it. So not only have we got this enormous number of women affected by the disease, but also Africans are far more genetically variable, and so that we are much more likely to pick up the genes that are of interest much more quickly than we will in a Caucasian population. So that, and Annette will just tell you a little bit more about that. So what else have we been trying to do? And I'm just going to tell you just snippets of a few pilot studies. And infection is a major problem in all across Africa in maternity hospitals. So Stephen Bentley is in the audience here, and this is Rosemary, one of our long-standing research midwives. And Stephen Bentley works on Staphylococcus and MRSA, and he sequences the genomes of bacteria, and by doing that he can track the bacteria, how they're moving through the hospital from patient to patient, nurse, visitor, whatever. And Stephen came out to Malago, and we done a pilot study looking at how the Staphylococcus is tracking through the hospital. And our aim there is to then intervene at the moments, the fairly key places that we will have barriers and not let people go across without proper control. And we have a microbiologist coming from Makerere University to the Sanger Centre to sequence all these samples very soon. And of course, one can't just do research without thinking about the clinical input to this, and these two must go hand in hand. And last week, I've just come back, in fact, from a visit with 8 clinicians and midwives and anaesthetists from Addenbrooke's, under Addenbrooke's Abroad, and they have been putting in guidelines on these major causes of death and training the midwives how to use them. And of course, this is only half the problem, the biomedical problem. There are, as we've heard, many social and cultural issues surrounding maternal health. And it's one of the most interesting things I think we have done in the last 5 years is collaborate with Sharath Srinivasan and Rainbow, who's here in the audience, Rainbow, who, on a project from Africa's Voices, which is a spin-out from the Centre for Governance and Human Rights, run by Sharif Srinivasan. And we did a pilot study with these interactive radio shows, asking rather simple questions about preeclampsia, what people thought it was, why they decided to go to hospital, why there were delays in getting to hospital. And I think it was very reassuring to see that we were able to get such a good response from women, and we're hoping to now expand this into other areas of maternal health. And lastly, I think we now, the Wellcome Trust Global Health Centre, one of the main themes of this is maternal health, and this is led by Dr. Watu Wamai, who's here, and she has a social science background, so she's been driving me to expand this area in Cambridge. And one of the things that we are now in a fairly advanced stage of planning is a textbook of African obstetrics, because it's quite, I'm sure it's quite obvious to you that European, UK textbooks are completely inappropriate in a setting where the disease is really such a, so different. And Watu has also been meeting up last week with anthropologists and social scientists from Macquarie University to, and we're going to have a meeting with, under Simon Goldhill and Crash, actually, to try and interact with the humanities departments in Cambridge to see how we can strengthen research across this other, the social and cultural barriers to maternal health. So I'm going to hand over now to Dr Nakimuli, who is the head now of obstetrics and gynecology at Macquarie University.